Today we're going to be talking with Dr. Sharma. He's with Atlas Neurosurgery and Spine here in Arizona. Their office is actually a great group of neurosurgeons. They have 3 neurosurgeons there, and we send most of our really difficult neurosurgery cases there. They're really strong at handling some of the most complex cases. So we love working with them. We thought it'd be great for you to be able to sit, listen to some of the things about their group, and we're excited to have this conversation. Today we have Dr. Ashish Sharma here with us today. So Ashish, you are a neurosurgeon. Most people don't have a lot of interaction with neurosurgeons. So what does a neurosurgeon actually do?
Well, I'm glad most people don't have too much interaction with neurosurgeons, but as a whole, neurosurgery involves basically taking care of from head to I guess pelvis. So all of the issues that go on with the brain, whether that's things like aneurysms, brain tumors, epilepsy, and the like, all the way into spinal pathology. That's the same things like tumors, but also degenerative changes. You know, when people have arthritis in their back and need decompressions, fusions, and the like. And in fact, there's other areas of neurosurgery like peripheral nerve where we deal even further out, like things like carpal tunnels and nerve entrapment, nerve transposition. So it really runs the gamut depending on what you want. There's even neurosurgeons who do critical care and run neuro ICUs.
I did not know that.
Yeah.
So really quick for people. So peripheral nerve is going to be a nerve after it exits the spine. Central nervous system is brain, spinal cord. And then anything that once you've left the spinal cord, it's peripheral nervous system. So you said that there are neurosurgeons that deal just with peripheral nervous system?
Yeah, there's actually a few across the country that deal almost exclusively in peripheral nerve problems. It's, people who have like brachial plexus injuries after they have motor vehicle accidents where they lose the function in their extremities, or even children with large shoulders during birth, where they can get stretching of the nerves, and you see kids with like a Erb's palsy. You used to call it like a waiter's tip because their hand will be bent. So doing nerve transfers from working nerves to others, and kids have so much plasticity that you can in 6 months, where it would take an adult
they may never recover
years to be functional, a child can pick it up in 6 months. So there's a huge field in neurosurgery that I feel like people don't typically associate with neurosurgeons. But
so I was going to ask you, like, on the topic of neuroplasticity. So again, neuroplasticity is the ability for the nerves to adapt and change and stuff like that. Are there things you can do to increase your neuroplasticity? Obviously, when you're young, you have a super high neuroplasticity. As we age, we have less than that. But are there things you can do to maintain your ability to change and adapt and stuff like that?
Yeah, I think it's similar to being physically adaptable. It depends a lot upon how well we maintain our bodies. Our minds and are sort of corollary to that. So the same things you would do, like you would exercise your body, eating right, maintaining a good eating habit is very, very important. Beyond that, making sure as we get older, unfortunately, the American diet isn't always the healthiest. Making sure that we're getting all of those minerals, taking multivitamins, things of that nature. Specific things that can increase neuroplasticity, there's been so much research into, and it's hard to recommend one thing or another just because there's a lot of evidence on both sides of it. But in general, keeping your body ship-shape physically and mentally kind of go hand in hand.
Okay, so for somebody, let's say, that's really, wanting to take care of their nervous system, they don't necessarily have any problems right now, but, health is important, nutrition is important to them. Are there certain recommendations or supplements or anything you would recommend to say for somebody that wants to maintain their brain and nerve health they should be thinking about or doing as part of their, routine?
Well, I think most people in their normal diets would probably get most nutrients that you would need, at least in the Western world. A daily multivitamin. In terms of jumping to things like spinal health, just like every other kind of joint, keeping your body weight as low as possible. I know that's tough just because of everything we just talked about, but staying active. The stronger the muscles surrounding your spine are, the more support they have, and the less likely they are to break down. And so, it's something that, that's becoming more and more kind of in the public eye with things like Pilates.
Yep.
And, but I think it's absolutely a very, very important thing, especially as we get older. We're living longer and longer. And so our spines, our joints in general didn't have to live 90 years of just a few decades ago, where now the average person can expect to live that long. So I think it comes with, if you want your car to last longer, you have to take care of it. Going and seeing your doctor regularly, making sure that you do your oil changes, make sure that you're taking care of your teeth, of your body, that you're exercising. And I think it's the small things that sort of add up, and that's when you see people who are in their 70s walking around and you're like, wow, that person looks like 20 years younger than they are. And beyond plastic surgery, that also unfortunately is something that confounds the whole thing. But in general, people who take care of themselves look and feel better longer. So it's a kind of a long-winded answer to that. But
no, I think it's good because a lot of the times the time when we're trying to fix stuff is when it's too late.
Right.
It's broken, and how do I fix it, rather than doing those maintenance things that you talked about. If we're exercising, we're eating well, we're trying to take care of our bodies, hopefully it gets it to where we never get to a point where it actually breaks down.
Right.
And so for neurosurgery, a lot of people think that, neurosurgeon, if I go see a neurosurgeon, they're going to do surgery, right? But there's other things that you guys look at and can recommend and stuff like that. So maybe talk for a moment of what does that process look like if a patient comes in, how you evaluate whether they need surgery, don't need surgery. If you're not going to recommend surgery, what are you looking for?
Yeah, that's actually a great point, and something that in every new patient visit I tried to address is that, about 80% of the patients that we see in clinic don't get surgery. So, I think you see a surgeon, in my opinion, to be educated on your options, to be educated on the disease process, and to be educated about the progression of the disease process and what we're going to do to stop it. And I would say that only when it gets to the point where only surgery would be helpful would I consider doing that surgery. So a lot of patients, I think, would benefit from coming to see a surgeon well before the surgery would necessarily be helpful. Like you said, with your example, we see stuff like that, all the time. It's hard to prevent heart attack after it happens. It's hard to prevent a brain hemorrhage from high blood pressure after it happens. Yep. But it's so you can think about it like going to your dentist when you are starting to develop a cavity. That doesn't mean they need to fill it, but now that you know it, you can keep an eye on it. They can do X-rays, and they can sort of follow it out. They can maybe recommend a different kind of toothpaste that you can try. It's stuff that you maybe wouldn't have known about. So when a patient comes to see me for, let's say, back pain, my first inclination is to figure out what's causing it, and so that we can discuss it as a group, because ultimately it's not my decision, it's our decision. It's a collaborative effort
between you and the patient.
Right.
Yeah.
And so having having that sort of like developing that relationship where they feel comfortable to sort of discuss everything that's going on with them, and then we sort of figure out what's going on and how we're going to stop it. For the majority of patients who come in with things like back pain, sciatica, the natural course, especially if it's early in their problem, is for it to get better. Most people with disc herniation get better within about 6 weeks.
Yep.
So if someone comes to me with an acute disc herniation and say, the pain's killing me, it's going down the back of my leg, my first inclination would be to offer them steroids, to offer them some physical therapy if they have a relationship with a chiropractor, if they have a relationship with a physical therapist, to do kind of other modalities, and then to see them in 4 weeks. And the majority of times they'll say, hey, you know what? You're right. I took the steroids, took the edge off. I've been going to physical therapy. Maybe I got a couple of adjustments, and I'm feeling much better. And we say, good. We're gonna put a pin in this. If this ever comes up again, come back and see me. There's times when it's more of a surgical problem where someone comes in and is like, my neck really hurts, but then after talking to them, they realize, I'm like, hey, are you having trouble with your balance? And like, now that you mention it, I'm falling down all the time. I just went to grab a jar of pickles and it fell right from my hand, but I just figured that was me being clumsy. And this is actually a completely true story that happened about 3 weeks ago with me, where a patient came in to see me for back pain, and they had gotten a whole body MRI. And in that, I noticed that they had neck problems. I'm like, hey, does your neck ever hurt? They said, oh yeah, every now and then. As you start going through it, they actually had pretty significant spinal cord compression and early signs of myelopathy. Now that's a condition that unfortunately does not improve with anything other than a space making operation, and you can only do that by doing surgery. But for every one of those, there's many more that are not surgical. So, but I think coming in and seeing that specialist, you can sort of work through what the next step should be, and you're already following with that person. So if it ever becomes a problem, you've sort of already kind of hooked into it. So I would highly suggest that if someone is having these issues, and especially if they're ongoing, it never hurts to get an opinion. And I think most reasonable surgeons would not offer surgery the first time that they meet a patient. So a totally reasonable fear, I think. I mean, no one wants to get surgery, but I think it's useful to get an opinion.
Yeah, I think that my history with talking to patients and everything, most patients they do have that fear, but they shouldn't necessarily. And I think that's really important. The good surgeons are not necessarily going to do right into surgery. They're going to say, let's understand this. And I think that's a huge problem that we have in healthcare, is that frequently we only look at the symptoms. And you said something really important that resonates with me a lot, which is when someone comes in, the first thing you want to do is what's causing this, right? And I think a lot of places in healthcare, it's what's the symptom, or what's the pill that treats that symptom type of a thing. And I think that's how we get to where we're at now with an opioid epidemic, right? Like people come in and they're in pain, and it's like, take care of my pain, take care of my pain. Well, yes, you absolutely want to take care of their pain. Right. But if someone's not asking the deeper question of, well, what's causing your pain? Right. And what can we do to fix that so that you no longer have pain? Then what happens is you're going to get on these pills, whatever the pills are, and then you're going to need more, and you're going to need more, and you're going to need more, and then that's where we lead into addiction and we lead into other issues. Because if you never treat the root cause, you're not going to get better. Right. And so that's something that for us is really, really important to say. Anybody that comes in, what's causing this? And if it's something that we think needs to go to neurosurgery or to surgery of any kind, it's a matter of saying, hey, we need to go there. And that's where we get that fear of, well, if I go, they're going to do surgery. It's like, not necessarily. Right. It's like we're seeing X, Y, and Z, and it makes sense. So let's maybe talk about that. What are the types of symptoms that, when present, would necessitate a really good referral to a neurosurgeon? So
I would say, one, pain that's sort of unrelenting. So if you've tried some of these, so if you tried things like physical therapy, like chiropractic care, and it's just not getting better, if you see kind of more concerning symptoms like loss of function in the legs, for example, pain shooting down the legs, having loss of balance, having trouble with their hands, especially, a lot of people have neck pain. We all have cell phones. We're constantly kind of looking down at them. So, people a lot of times will attribute, it's like, oh, my neck really hurts, or, things like waking up with your hands being numb. Like what a common thing. It happens to me every now and then. But, having these constellation of symptoms that on their own don't seem that weird. It's like, oh, I'm in my 70s. I feel like the loss of, I'm not as balanced as I used to be. Maybe you're losing a little bit of strength in your hands, maybe you're starting to drop things, having trouble buttoning your buttons or tying your shoelaces, and you're just like, oh, that's just old age. That sort of constellation of symptoms, I think, tends to make us more worried that there's something else going on. Sure. And if we look and there isn't, then that tells us something. Then we have more information to relay to the patient, and we can discuss about what else could be causing it. But if I see those sort of warning symptoms, my first inclination is to rule out anything that's going to cause them irreversible damage.
Yeah, I think that to go see a neurosurgeon, usually people can be either too early or too late, right? And I think we see this a lot. And too late is, we talk to a lot of patients, and maybe they don't have a lot of pain, and they're like, this is what I hear. It's only numbness, so I don't think it's a big deal. It's only weakness in the muscle, it's not a big deal. And, that's scarier than pain, because once we know that it's actually affecting, sensory, if it's affecting muscle, especially weakness, then we're seeing, the nerve is for sure involved. Right. Or if it's just pain, it could be the tissue surrounding the nerve, it can be other things. And so a lot of people minimize that, and sometimes people wait too long, and then they come in and, they have drop foot or something like that, and they're like, Like, is this bad? It's like, yeah, but we're gonna get you in right away to see somebody, and that's when we send them, to you. But the nice thing about whether it's too early or too late is I'd always rather be too early
Right.
than too late.
I completely agree.
Right.
I've seen patients who were referred, even without imaging, where patients sometimes self-refer, for just pain. And when you get to talking to them more, you realize the thing they're coming in for is pain, but then they have those other symptoms, but they don't matter as much because it's like, the numbness, I can deal with that. The weakness, I mean, it's not that bad. But from a surgical perspective, that's so much more concerning. So if that pain brings them in to at least be evaluated, that's totally fine. If they come in and it's like, this is not a surgical problem, we're just going to do some physical therapy, at the end of the day, it's not a wasted visit. It's still, we got something out of it. So my inclination would be, this is what I tell anybody who I talk to, is if you feel like you need to see me, just come and see me. And if it's something we decide that you're not going to need my services, that's the best possible news that I can give you.
That's the best news.
So I don't have any problem with that. I know that sometimes people get as we get busier, there's this, if this isn't going to be, quote, worth my time, I don't want to see this patient. I personally don't agree with that, because at the end of the day, I do like it when I can fix a patient's problem without needing to do surgery. So I mean, if someone doesn't necessarily meet all those criteria and they just want another opinion, I mean, it's 30 minutes of my time, and I'm more than happy to share it with the patient.
I think that's such a great attitude of like really focusing on, I'm here to listen, I'm here to help, and not to go straight to, what, everybody needs surgery. So I love that you guys do that. So I'm going to switch gears on you for a moment. We talked a little bit about opioids and treating symptoms rather than treating the root cause. In your opinion, what are some ways that we can help to solve the opioid epidemic?
That's a hard question to answer. I think the opioid epidemic, the way it started, was multifactorial. I think a lot of it was driven, it's sort of the road to hell being paved with good intentions. Because like you said, the opiates are prescribed to help people. Yep. But there's no free lunch. Every medication has a side effect, and by definition, they are addicting, and we become tolerant to them. So literally, it's by design, you will need more and more and more, right. And then you'll become dependent on them at some point, to the point where it's even super high doses are just barely treating the pain and making the patient functional. So how do you fix that? Well, one, you stop contributing to it. Yep. So I think it's sort of like if you have a sink that's leaking, the first thing you have to do is turn off the water. So we have to stop adding to this number of patients who are suffering from this problem by, like you said, figuring out what's causing the pain. Yep. And trying at first. I mean, some pain unfortunately is not fixable. Yeah. There's a lot of patients, who have, for example, cancer that's metastasized to their bones. Literally, the only thing we can do for them is manage their pain.
Medicate. Yep.
There's a lot of times where, when a patient comes in with pain, there's the first instinct is to just offer them something for the pain without necessarily looking into exactly what it is. Because honestly, if you could be on narcotics for 3 months after surgery, as opposed to years and years for a problem, I think most patients would prefer that. Yep. So if it's a problem that is fixable, then we should work on fixing it, because you're just sort of masking the symptoms. Once we get to a point where we're only treating people with opiates as they were designed to be used for kind of acute pain. The only people with chronic pain who really were we use opiates on were cancer patients. Cancer, yeah. And unfortunately, there's a big subset of patients where there's unfortunately no other treatment that can be helpful to them, and in those patients, we have to do what we have to do. You can't let someone live in misery. But I think if there is an opportunity to sort of figure out, especially at the beginning, like that first visit, the first couple of visits where someone's coming in, if we can steer them toward a cure instead of Band-Aid, I think that would help a lot. And then, it's really hard to cut someone back on medication that they're not addicted to, like mentally, but physically dependent on. Like it's cruel to try to try and basically put someone into withdrawal just to make a number look better. That, oh, we got you off opiates. But I think the first step is to stop adding to it, and then kind of helping to use there's a lot of adjunct treatments as well for pain. So within neurosurgery, actually, there was something actually being pioneered at the University of Maryland where I trained. It's the focused ultrasound, and it's focused ultrasound for thalamic targets, and the thalamus is a nucleus inside the brain that basically acts as a relay center for all of the sensory input from your body, and it's intimately involved in pain regulation. So for a lot of patients who have, for example, CRPS or complex regional pain syndrome, and post-herpetic neuralgia, things like that, we've actually done focused ultrasound ablation. Really? And they've had 85% reduction in their pain outcomes.
Wow.
Because it disrupts those circuits. It's basically using MRI to focus sound waves with basically a bunch of quartz anodes, and you focus all the sound waves on one area, and they can hit like sub-centimeter targets. And just selectively lesion those or modulate them. So depending on how much energy you put into it, you can heat it up to a point where it's modulated versus ablate. And now it's being used for things like Parkinson's as well. So instead of deep brain stimulation, where you need to have a surgery, you literally, the only surgery is basically shaving your head. Yeah. And you go in an MRI machine, and we can lesion that area of the thalamus or subthalamic nucleus that we were going to modulate with the deep brain stimulation, and we can do it without making any cuts on your head. That's incredible. And so similar to that, things kind of going down the path of neuromodulation, there's also things like spinal cord stimulation, which for non-surgical back pain has had excellent results, where surgery for non-surgical back pain, as the name implies, doesn't do very well.
Doesn't do well.
And just sets people up for the future, for future problems. So I think having that multimodal approach, I think just as important as knowing when to do surgery is when not to do surgery.
Absolutely.
And I think that's where a lot of the, especially in the pain game, it's so interesting, the new modalities that are sort of coming up.
Like you covered so many things, so I'm going to try to unpack a couple of things you said, because there's so much good stuff there. So one was on the opioid epidemic, kind of where we started on this, which is, like you said, it's treating the root cause. And I love how you said the road to hell is paved with good intentions, because I feel like this is how it happens for most people. They go to their primary care, because that's where most people go first when they have some type of pain.
Right.
And their primary care says, I'm gonna give you something, and maybe they prescribe an opioid or something else because you're in a lot of pain, and I don't treat pain, so I'm gonna give you something, and then I'm gonna send you to a pain specialist. And then they come up to a pain specialist and they say, like, here at Arizona Pain, when they come in and they're already on a prescription, it's like, okay, well, you're on a prescription, now I have to manage that prescription.
Right.
And what happens is when they come over in that setting, oftentimes a lot of places don't go deeper than that. It's like, okay, now you're on a pill, we gotta manage this, we gotta do this, and over time, you never get to that root cause. Where we really try to be different is say, okay, well, you came over on this, what can we do? Now, what we would prefer is they come straight to us and we never get them on that opioid, and we can say, okay, you have a herniated disc, let's do an epidural to try to get the inflammation out of that disc, let's do some physical therapy to strengthen the musculature of the core, let's do chiropractic to get that area moving, and all of the other modalities we can do, because that brings us to that second part that you said, which is one of the best things we can do is not contribute to these people to where we're getting more and more people on drugs. But I believe that there's another part that you touched on, but I want to emphasize, which is one of the best ways I feel to solve the opioid epidemic is actually great communication between multiple specialties, right? So if instead of saying, that primary care is putting them on a pill to send them to a pain management group, part of that reason is they don't know how fast someone will get in. Right. And they're like, okay, it's going to take a month for you to get in somewhere, so we'll give you a month supply.
Right.
Whereas if we had better communication between primary cares and pain management and surgeons and stuff like that, I feel like the communication would solve a lot of problems of doing what you said, which is identifying the cause and then aligning treatment to that cause as quickly as possible. And that decreases reliance on concentrated chemicals and drugs to control pain, and instead allows us to say, let's fix what's causing it. And then maybe there is some med management along the way, but we haven't built reliance. I was talking to a patient who once said, I don't think it's addiction. I think it's pain, right? And that's the matter of these things get so together of, are they really addicted to something, or is their pain so bad that they're afraid that if they go off of a pill, the pain will be uncontrollable? And so I do think that there's a psychological component that needs to be handled. I think the pain needs to be handled. And lastly, trying not to have that addiction part.
Yeah.
But you actually beat me. So moving on to the next part of what you said, because there was so much good stuff, is I was going to ask you, what are some of the coolest technologies that are coming down the line from either in neurosurgery and other stuff that you've seen that you feel like are going to have a huge impact on healthcare for the next couple of years?
Yeah, so, sorry, I kind of jumped ahead there, but that's
you didn't jump ahead. This is great.
No.
So I think the focused ultrasound is amazing. And is there other things though that you think that are coming down the line that will change stuff as well?
Yeah, and I mean to your point about, is their pain real or not? I absolutely think people with chronic pain who are on these medications, their pain is 100% real. But over time, so these medications, the receptors that they work on in the brain from being repetitively stimulated by these drugs, you basically, and which is what causes them to be less and less effective over time. It changes the pain regulation inside of your brain.
Those neural loops, yeah.
You literally feel they feel pain differently. They become hypersensitized to pain, and it's obviously not their fault, but they then start to feel pain at a much lower threshold than they would have otherwise. And so then, it sort of becomes like you're like chasing your own tail, and you end up giving them more of the thing that's causing the dysregulation.
So essentially you're saying, like, just like we form habits, our nerves actually can form habits to where if they're firing over and over again repeatedly, that's now their constant state, and that's what creates that hypersensitivity. Is that right?
That's a great way to sum that up. Exactly. And you can get used to anything, right? I mean, we're creatures of routine. Like, think about the first time you ever drove a car versus now. You could probably be listening to a song and you end up where you needed to go. You don't remember turning, you don't remember, but you got exactly where you needed to go without thinking at all. So, I think our brains are really good at adapting to whatever's happening. So if you're in a state where your neurons are bathed in that drug and they're used to it, they then basically need that becomes the new normal, and that dysregulates that whole cycle, and then it's chicken or egg at that point, and it's really, really hard to control. But to your other point, so new technologies, yeah, it's a really, really exciting time for functional neurosurgery right now. So we're learning so much about how we can change all sorts of things in the brain just with modulation. So now we're doing deep brain stimulation for
Parkinson's and stuff like that, right?
for Parkinson's. Now we're doing deep brain stimulation for depression.
Oh, wow.
For seizures, because you realize that if you and it makes sense. A seizure is basically a dysregulated circuit in the brain. They're like, what if you put a wire in between that circuit and disrupt it? Would it stop the seizure? And
it does.
And it does. So that sort of opened the door with what else can we modulate. And that's where this pain, treating pain in these people is so difficult to treat pain in. Like complex regional pain syndrome, one of the absolute hardest and most debilitating treatments or problems to have, where people can't even stand having a sheet covering their affected body part. You could literally just lightly brush your hand and it causes just lancinating, burning pain. And to the point where you need to put pants on. They're like, a patient's like, I can't put my pants on because the pants rubbing on my leg is just excruciatingly painful. And so being able to then regulate how it's like, what causes the body to feel that pain? Can we regulate that? So there's many ways to do that. Can you stimulate at the nerve level? Can you stimulate at the spinal cord level? Can you stimulate at the brain? And the answer to all three of those is yes. And so there's been promising. There have been really promising treatments on nerve stimulators, on spinal cord stimulators, and in this focused ultrasound doing ablative procedures higher up in the brain that can basically stop pain, because it has to go stepwise. You can stop pain here, here, or here, and for different patients and different indications, people respond better to one or the other. But yeah, it's really exciting to have these things to offer patients, because in the past, with CRPS, it was I'm sorry.
Yeah, like what else can you do besides medication?
Nerve
right?
medication. We could put you on some gabapentin,
Lyrica,
Lyrica, something like that, and it didn't work. Well, we can try some other medications
or
like
I guess you're gonna have to live with it, right?
Antidepressants. Essentially, because you're
depressed.
You're depressed, and then we want to get you to the point where you can be semi-functional. Yeah. Where now, even just the prospect that we could offer those people a permanent reduction in their pain is really exciting. So, I think in the next few years. So, I mean, we were participating in that trial now, and there's a few centers across the country that are doing it, and it's really really interesting. And I had to learn way more physics than I did for years and years about it beforehand, because it really depends on like the thickness of your skull, the shape of your skull, because the sound waves have to basically bounce through they have to bounce through your skull and basically converge at one point. So if you have irregularities in your skull, or if your skull
the math of how you get there. Oh my goodness,
or if your skull
crazy.
is too thick, or if it's too thin, or if it's too dense. So in some of our female patients, females have on the whole lower bone density, we're having trouble focusing the sound waves enough to heat that area enough to be ablative.
Wow.
So then we ended up having to do like a small basically incision on the skin, and replacing maybe about an inch of their skull with a plastic material.
Just so you get the thickness that you need.
That's 3D printed, and because it's the material is perfectly made to bounce sound waves through it.
Wow.
And so it's like, but like stuff that seemed like science fiction, even at the beginning of my training, seemed like complete science fiction, is now in the realm of possibility. So I think
such a cool time to be alive, though.
Right. Then that's what comes with being like, if a patient were to come to me and were to talk to them about this, odds are, every time I talk to patients about, the fact that, even diabetic neuropathy in their feet, it's now, there's an FDA approved indication to do spinal cord stimulation. Yep. Even other doctors are completely surprised by that. They haven't
even heard of it.
They haven't heard of it.
And so they haven't recommended it because they don't know.
And that's where it comes, where you're like, oh, should this person go or not? My thing is, and for me, this will always be the answer. If someone ever thinks, does a person need to go see a surgeon? The answer is always yes. Because the worst that's going to happen is they're going to go find out that that we can't help them, or that we can't help them with surgery, and that there's other things that we can do. But I absolutely think that otherwise you wouldn't know about any of these things. So
like, we do a lot of neuromodulation. Yeah. We love it. We think that it's one of the procedures that gives us more, I don't know if you want to call it hope, but definitely satisfaction in what we do, because these patients, whether it's painful diabetic neuropathy or CRPS like we talked about, a lot of these patients have been told, there's nothing really we can do. You've tried Lyrica, you've tried gabapentin, you just got to live with it, right? And so to be able to have these patients, they come in and we say, hey, there's something we can do for this. And it's it's not medicine, it's not narcotics, it's not, something that you're going to be reliant on. Instead, it's a procedure that we can do, that you can try to see if it works first. Right. And then we can actually see if it does work, we'll do that. And we're getting, 80 or 90% relief doing these procedures. Let me clarify. 80 to 90% of people are getting 50% or better relief with these procedures. And to us, that's amazing. But one of the most common questions we get is exactly what you brought up. Patients come in and they say, how come nobody ever told me about this before? And it's not because their doctors are wanting them to suffer. It's because a lot of people still don't know about some of the advancements in technology. So they can't recommend it because they're in their space, they're in their realm, they're in their specialty, and they're working as hard as they can to keep up with their specialty. But there's so many other specialties, and they're all advancing technology as fast as they can. That's the fragmentation in our healthcare system that, again, leads to either unnecessary procedures, reliance on medication, or just people not getting better. Right. I feel like the better we do at educating ourselves, the better we do at working and collaborating together. Again, I have a strong belief that when doctors talk, patients get better. Yeah. And that's a very big belief. But I love that you brought up neuromodulation.
No, absolutely. I think that it's just unreasonable to expect any one doctor to just know everything. There's so much. There's so many advancements that were made in every other part of medicine during just my training that I'm not up with the time. So I'm like, your primary care doctor will definitely have medications to offer you for things that I learned about in medical school a lot of that training is completely irrelevant now.
Yep.
And so I think just like that, even though they had training
And it was good training.
And they're
a good doctor.
in the neurosciences, they might even keep up with it. It's just, it's really hard. I think, frankly, it's too much to expect, a primary care doctor to, because they're not just treating patients with neuro, to basically have them be completely up to date in every single subspecialty that they might refer a patient to. But I think that's where specialists come in. I think our role is primarily to educate patients on their options. I think surgery is a small part of being a surgeon. It's the majority of it is seeing patients before, during, and after surgery. It's making sure that they understand what's happening to them and what will happen to them. So I'm really glad that you brought that up. I think that the communication between doctors is so important. I myself make it a point to reach out to whoever referred me a patient after I see them, just to close the loop.
Yep.
Like, hey, you sent me this person. I'm going to send them for this additional imaging, and I'm going to follow up with them. And I'm gonna see them in so and so weeks, and then or if they send me a patient like, hey, this guy's had physical therapy, this guy's already had injections, he got better, I think he needs surgery. I'm like, I agree with you. We're gonna work on getting him scheduled for surgery. But then they know, and I think them being comfortable with me is just as important as the patient being comfortable with me. Because as we foster those relationships, which are much easier if you work in one hospital.
Yep.
But it's a lot harder when you're in a big
like
metropolitan area like Phoenix, that you're not seeing that same person. They're not in your, like, they can't just look at your notes that you're putting in.
It's in the system.
Yeah, you're not in an integrated system. So I think having that line of communication always be open is so important. So I completely agree.
We were talking about this earlier, but there was some research that came out. I think it was UCLA that talked about how important bedside manner is, and the correlation between people that have really good experiences with their doctor's bedside manner wise and outcomes from surgery. And I just think it's so interesting that when 2 weeks ago, we were doing an interview with Dr. Mirzadeh, and we talked about placebo and how important belief is in any type of care. And I think it's very similar of, you need to believe in your doctor. Right. And when you believe that your doctor can help you, you're more likely to be compliant, you're more likely to get better. But also, you mentioned, doctor means teacher. Yeah. I'd love for you to talk about that a little bit, of what, because again, we were just talking about communication is important, but I think it's more than just communication.
Right.
It's actually teaching and creating understanding, right?
Yeah, I mean, I like to think about it in the same way as, the best teachers engage their students. Engaged students make better students. Engaged students will then apply themselves outside the classroom, and they're the ones that end up doing the best academically. Yep. So if you can find a way to engage the person that you're trying to have discourse with, I think you're going to have a much more fruitful kind of relationship. And so with the patient, what like you said, the word doctor comes from doctore, to teach. That's where kind of it all started with PhDs. And yep. So I think my job as a specialist is to teach the patient what's happening with them, to teach them about their options, to teach them about the natural course of the problem that they're having, so that they understand. The more they understand, the more they're going to be invested. Mm-hmm. And the more they're invested, the more they're going to be able to do to help themselves out. It's like you said, if you don't know what you're supposed to do, it's hard to do that. So, if you foster that sort of relationship with the patient, where they feel comfortable with you, where you can have that engagement, where they feel comfortable back and forth, talking with you about stuff, I think that makes them really take ownership of their care.
Yep,
where a lot of times it's the doctor's doing,
he's in charge.
Now
that I'm here, I can just here's my issue.
Be like what are we doing? And the answer is I don't know. So I mean, my whole philosophy is surgery is the least of it. Like, even if you do get surgery, your surgery is going to be 2-3 hours of your time, and you're going to spend months afterward, going through rehab, basically getting back to where you feel like you're able to do what you want to again. So I want patients to be to be aware and to be participatory in their care, because I think, like you said, that improves their outcomes. If people feel like they're just kind of passengers in their own care, that doesn't really, that's where the whole paternalism in medicine has gone by the wayside, and I think rightly so. Is that, you know, people need to feel like they're involved, because ultimately it's their life.
I actually think that's like the best advice to patients is, you know, oftentimes, you know, Dr. Google and all these things come out, and yes, there can create a lot of confusion and things like that, but the desire to be educated on your care is a good thing. Absolutely. Like the fact that you're researching, the fact that you're wanting to do that, that should not be discouraged. In fact, we should be, yes, like, here's good information, here's good resources, here's things you can learn about this, because the more engaged they are, the more likely their outcomes are going to improve. And so as much as I know that that gets frowned upon in general in society, I love it when I hear that. I'm like, I'm so glad that you're wanting to participate in this. Let's get you some good resources, some good information, so that you can learn what you need to learn to take care of yourself. Because if you're part of, like, it is a healthcare team, and it's the doctor and the patient together that are going to say, these are the best outcomes for you. You got to match that.
Right. And, you know, interesting, when you talk about outcomes too, you know, I think so much of, you know, outcome is based on what the patient expects. Mm-hmm. So I think a lot of it is, like you said, like we talked about, education. So, for example, with spinal cord stimulators, you said 85% of people have more than 50% reduction in their pain. If that's something that you talk to, you know, the patient about, that, you know, to manage their expectations, to understand that, you know, this is an option to reduce your pain. Yep. This is an option to bring you back to that functionality, so that this pain isn't stopping you from doing the things that you need to do, but that it will not get rid of the pain.
Yep.
You know, and then if that person wakes up and their pain's much better, their outcome will be positive. Where the exact same patient,
their expectation is it's gone.
Where their expectation is, oh, I'm going to be pain free. They're going to be like, this is worthless. Yep. I'm still feeling pain, because they were expecting nothing. So I think that
setting expectations is
so important in outcomes, and I think that might also kind of go into that bedside manner that you talked about.
Yeah.
You know, more satisfied patients are patients with more realistic goals.
Have the right expectations. Oh, I never even thought of that. I love that.
So I mean, if they've been educated properly, then they're not expecting, you know, they're not expecting a miracle.
It's the exact same results, but the perception of the result is different.
And ultimately, if they're happier, then it doesn't.
We did our job.
We did our job.
That's right.
So I think a lot of it is about managing expectations and knowing our limits. I mean, I don't think I've ever promised a patient that they would be out of pain, you know, from an operation, because I think that's an unrealistic goal. But my goal is, if the pain is limiting in your day-to-day life, it's stopping you from doing the things you want to do, my goal is to get you back to that. And if the patient understands that that's the goal, then when they reach it, then they're satisfied, because their expectations match reality.
So our chief medical officer, Dr. Church, one of the things he says when he talks to neuromodulation patients, he says this, he goes, we're talking about their pain, we're talking about the dysfunction of how it's affecting their life, and he says, if I could, you know, flip a switch and decrease your pain by 50%, would you be happy? And if they say, yes, that would be amazing, that would be life-changing, and they talk about how different that is, like, okay, then I think this could be a good option for you, right? Because, like, it's setting that expectation of, we're going to set it at 50% decrease,
right?
Because oftentimes we're getting like 80, 90% decrease, which is fantastic. But if we set the expectation at 50 and you get 50, we met that expectation. But if we exceed that and we get like 90% relief, person's over the moon. And I think that's really important, of making sure, because different patients respond differently to different treatments, we need to say, this is like the minimum threshold of which we feel like it's success.
Right.
If we set the expectation there and they go over it, we're great.
It's great.
But if they meet it, they're also happy.
Right.
And if we don't meet it, then we say, this isn't the right modality for you, and it allows us to work well with patients. So spot on the money there.
Yeah, no, absolutely. That's the guiding principle of a patient-doctor relationship, is that you need to know, like, all your cards need to be on the table. Like, everyone needs to know where everybody else stands. And so much of, you know, people feeling like they didn't get what they wanted to or what they needed to out of a procedure, a surgery, physical therapy, is because their expectations didn't match what was going to be possible.
Yep. So let's switch gears for a moment. I know that your background in your study, you did a lot of structural deformity in neurosurgery. I know, like, so let's do this first. What are the different, like, subspecialties within neurosurgery, and what drew you to deformity?
Wow. It took me probably halfway through my training before I decided on spine and then deformity after that. But so the major subspecialties I would say are oncology, that's tumors. Cerebrovascular, that'd be things like aneurysms and arteriovenous malformations, things of that nature. There's epilepsy, but epilepsy and functional tend to be kind of hand in hand. So that would be seizures, people with pain disorders, movement disorders like Parkinson's, essential tremor, peripheral nerve, which we talked about earlier, and then critical care, which is there's some actually go back and do critical care fellowships so that so they can run like a neurocritical care ICU.
Even more school,
exactly. So spinal surgery, basically from the occiput down to the sacrum, it involves treating the nerves predominantly. So I know that both orthopedic and neurosurgeons do spine surgery, but I think we come at it from a slightly different perspective. So
yeah, I was going to ask the question. People ask me that all the time, like, should I see an orthopedic surgeon or a neurosurgeon? So please answer that question. Like, what are those different approaches?
So I think at the end of the day, we're doing the same surgeries. So it's similar to seeing like an orthopedic surgeon versus a plastic surgeon for your hand problem.
Yeah.
It's like seeing a facial plastics person or an oral maxillofacial surgeon or a plastic surgeon or for a facial problem.
No wonder patients get confused.
Right. So I mean it's sort of in a way it's kind of dealer's choice, but our philosophies fundamentally are different in where we arrive at the spine. So neurosurgeons tend to think of the spine from the nerves out. Oh. And orthopedic surgeons, I think, tend to think of it from the bone in. So at the end of the day, you get to the same place, but you come at it from a different perspective. I think in the 70s and 80s, orthopedic surgeons were more involved with the bony problems that we see in the spine. Whether that's scoliosis, like deformity, people with like hunchbacks that you see, or fractures in the spine. Where neurosurgeons were more involved with when the nerves were compressed, people had sciatica, when people had tumors in their spine. And then it sort of started to overlap, where both people sort of treat everything now. So really, I think
they're not going to do brain surgery though,
you
will, or anything like that.
that's pretty much the only thing.
Where it's spine, there's a massive overlap, but when it gets to like brain surgery,
endovascular, that was the last one. I was forgetting one. That's where we use catheters inside the blood vessels to take out strokes or to put coils into aneurysms. So I guess it's cerebrovascular. It's like another subspecialty. But one of my mentors in training is a dual trained cerebrovascular and endovascular. So I feel like he'd be really upset with me if I forgot his if I forgot his subspecialty. But so, at this point, I would say there's a fair amount of overlap. And I think orthopedic surgeons are also trained in treatment of the nerves, and neurosurgeons are also trained in the treatment of the bones. My fellowship was actually in both. So I actually did my fellowship with orthopedics and with neurosurgery. So I kind of got an example from both sides. So at this point, I think it would be more about the surgeon which you can form a deeper kind of rapport, a personal connection with, someone that you feel comfortable. Because at the end of the day, even the least complicated, straightforward, minor surgeries, as we say, can have disastrous complications. When we say there's like a 1% chance of something happening, if it's a surgery that happens hundreds of times a day,
it can still happen.
It could still happen. Yeah. So at the end of the day, you want to be with the person that you're comfortable with in a stressful situation like that.
That makes sense.
So that's why when patients come to see me who've seen other surgeons and they say, should I have this done by you or by them? It's always whoever you're more comfortable with. In technical ability, I don't think that you can reasonably say that one is better than the other. I think there is some difference in the training in that, during neurosurgery, we tend to do spine surgery throughout our training.
Yeah.
For all 7 years, where in orthopedics, just because they have the whole breadth of the skeletal
joints
system,
and everything else,
they end up spending maybe quite a bit less time on the spine, but then they go on to do spine fellowships, and I think the gap narrows considerably at that point.
I just want to point out like how good of advice that is for any patients that are out there, which is frequently people say, who should I see for what? And the advice that you just gave, I think, I just want to underline it, which is where you're comfortable is where you're going to get better results, right? So when you're looking for the doctor, you're trying to make decisions, make sure that's one of the most important criteria that you're looking for is how do I feel when this doctor's explaining things to me? Am I comfortable? Because ultimately that's one of the most important things when picking your doctor.
Right. Yeah, I mean, because it's like you said, not only in specialties, but if you were to go on Google and type in spine surgery, I mean, just in the Valley, there are so many people that come up, and you know, like, well, how is a patient to tell, you know, oh, is this person better than this person? You could compare them. It's like going to a Google or Yelp to look up a restaurant.
Yeah.
You know, there's thousands of reviews. Everyone has good reviews. You're like, oh, well, and unlike a restaurant, you don't know, it's not a different type of food that you're picking. It's like they all do everything. Yeah. You go on their websites, all their websites look great. So, you know, at the end of the day, you know, the only way that as a patient that you're going to know is if you go and you feel like you have a rapport with that person, then I think it makes sense to move forward. If you feel like there's not that sort of connection, I think it doesn't make sense to have, because surgery is a very intimate experience.
Yes.
And you want somebody who's going to be able to guide you through that period where you're going to be extremely vulnerable. I mean, it's not a good time for anybody. I was going to say most people, but I don't know who's having a good time
looking forward
immediately
to get surgery.
After surgery. So, you know, when you're in that state, basically the person that you'd want to have in your corner is who you should pick to get you there.
It's great advice. So, you know, as we're wrapping things up, couple of last questions and comments. So, like in deformity, that's what you ultimately decided to specialize in. So what type of treatments or what type of conditions does that entail?
Yeah, so in deformity, you know, the basic principle, if I had to break down deformity into one principle, is that your head needs to be above your pelvis. So the way that we walk, the cone of economy, essentially from where your pelvis is to where your head is, you can move it 5 centimeters in any direction before your body starts to freak out. Yep. And so if you're hunched forward too much, you know, if you're walking and you feel like you're constantly having to tense your back to stand up straight, you can do that for 30 minutes. You can do that for an hour. Eventually it gets to the point where it's unbearable pain. Yep. If you have an S-shaped scoliosis that ends up with your head being you know 5 centimeters translated in either direction, eventually it gets to the point where you start to have trouble just walking around.
Yeah, biomechanically it starts to
get
off. Yeah.
And then your scoliosis can get bad enough that it prevents your lungs from expanding properly. Yep. You know,
late stage scoliosis, heart, lungs become huge issues.
Absolutely. And so, you know, in those conditions, seeing someone sooner rather than later, you know, even if it's just a monitor that the scoliosis is getting worse, is important. There's a completely different type of scoliosis in children because they're growing. Yeah. And so in those instances, we typically will monitor them with X-rays. If their curve is continuing to progress and their skeleton is not mature, then you know at a certain point, you know, it really depends on the curvature depends on what literature you're following. But you know, maybe about 30 degrees or greater, and someone doesn't have a mature skeleton, you might brace them. Yeah. But then, you know, after you know 16, 17 years of age, when the skeleton's mature, at that point, it's more of a cosmetic issue than anything, until they get into like their 4th and 5th decade of life, when you start to get basically a very rapid advancement of their
as it starts to degenerate,
of their degenerative problems
and stuff like that.
So the kinds of treatments that we would do, you know, kind of go hand in hand with everything that we've set up to this point. The first would be things like strengthening the muscles, physical therapy, chiropractic manipulation. But you know, if it came to the point, like especially with kyphosis, because that's probably the worst tolerated.
Like a kyphoscoliosis.
So you know, if you're really hunched forward, it's just really hard. You know, you see these patients talking about how after 5-10 minutes of standing, their back hurts so bad that they that they can't function. They're having trouble like looking up.
Yeah.
Like when they're crossing the street, they can barely look up to see the walk sign. In those cases, unfortunately, that's where therapy kind of
stops being effective,
and we need to do a bigger operation, and that would be something like a pedicle subtraction osteotomy or a vertebrectomy. That's basically cutting out a wedge of your bone and like in a triangle, and then collapsing it to basically bring your whole head back, or even taking a whole vertebra out to be able to.
If you have a hemivertebra, so again, a hemivertebra is like the vertebra is not fully formed, and that causes a lot of these scoliosis, or some of the scoliosis is from a hemivertebra. Would you just take that out?
So no, not usually. So usually with those are compensated. Mm-hmm. So usually those tend to happen a little bit higher in the cervical spine as well. C2-3 is the most common place. In that case, it might cause your X-ray to look a little bit weird, but for the most part, we can get by on those by, if it gets bad enough, to do just a decompression. If it gets to the point where it's actually causing like a cervical thoracic or from neck to the shoulders to fall forward, then we have to do another one of those procedures to basically cut the bone and basically disarticulate your spine and essentially bring it back and lock it in place. And those are, as it sounds, a very big operations.
Big procedure.
But they can be procedures that result in immediate improvement, because the patient, when they stand up for the first time, realize they're looking forward and not down.
Wow.
And
life-changing.
And it is, yes. Like my back hurts a lot, but I can literally see straight, and I can look up at the ceiling where I could not do that before. And so those surgeries, I think, are the most complicated, the most dangerous, but ultimately also some of the most rewarding.
So I have scoliosis. I should say it's a lateral curve now, and I'll get into that in a moment. But like my grandma had scoliosis, super bad S curve. Fully, like by the time she was 80s, in her 80s and stuff like that, it was like collapsing, 70 plus degree like S curve scoliosis. She lost over a foot of height.
Oh wow.
And was like completely hunchback and stuff like that. What's interesting though is like my grandfather was a chiropractor, and he got into that in part because my grandma he was in the FBI before that. So he was in the FBI and had a successful career there, but my grandma was having back pain all the time. And so he started looking into chiropractic and thought that could be a really good modality, and went to chiropractic school, became a chiropractor, and that's where a lot of my family now actually are chiropractors because of him going there. But it all started with my grandma having the scoliosis, and surgery wasn't an option for her, and so adjusting her, and it probably would have been now, but back then there was some sacrifices that had to be made of fusing the spine in ways that just didn't work for her. But anyway, he was able to manage that pain associated with the scoliosis to where she was able to live a somewhat comfortable life through chiropractic. And I think that's one of the reasons I'm a big fan of chiropractic. As far as my back, so I have scoliosis. We did something really unique with my back. I wanted to get your opinion on this. So I had a 28-degree curve on my upper and like a much smaller. So it was a 28-degree lumbar right, so dextra, and then a like 18-degree left in the thoracic. We did manipulation under anesthesia to just stretch it out, and then we did injections of stem cells along my back as well. I get to experiment on myself. It's okay. It's not other patients, right? But we did that, and post-MUA, manipulation under anesthesia is what MUA is, and we went from a 28-degree curve to an 11-degree curve on my back.
Oh, wow.
Which is pretty cool.
Yeah.
And so I had 6 months of like, my back was feeling amazing. There was no pain. Like it felt incredible. Now it's starting to get a little bit more stiff after that, but this is an example to me of like, there's really cool things that can be done as we continue to research and continue to look at stuff. Obviously, this isn't the type of care I would recommend for most people. This was something that I wanted to try on myself because I felt like there was some cool technology that we could try.
Yeah.
But for most people, one of the things I wanted to ask about is what are some of the more advancements that they've made in scoliosis care? I've heard of, because I have scoliosis, I try to follow it a little bit, the 3D printing of spines to where they can actually then show what it would look like pre and post fusion and how it would work on that. Yeah. So what are some, like 20 years ago versus now, what can they do for scoliosis that maybe most people don't know about?
Yeah, actually there's a really exciting platform called UNID. It's actually, it's through Medtronic, which is one of the spine companies. They they actually will. So it's a machine learning algorithm that has about 100,000 patients in it, and it's basically they have all the pre and post operative parameters, and they have whole spine images of them pre and post surgery.
Oh wow.
And based on that, they can, using that machine learning algorithm, they can actually predict, if you were to do surgery on someone, what their spine would look like post-op. And then as you use it, it becomes even better at judging how, if you were to do the surgery, because every surgeon, the
different style.
Yeah, the difficulty with standardizing or kind of outcomes in surgery, especially as it results to in degrees of curvature and such, is there's so much individual variation in how people do surgery. But I think dividing that across so many different surgeons and then having this algorithm basically pick out like a median. So it'll be like, if you were to do an anterior lumbar fusion, so you can basically spit into this. You can be like, I want to do an anterior lumbar fusion at L5S1. I want to do a T4 to pelvis fusion. I want to do at L4 pedicle subtraction osteotomy. I want to do PCOs at this and level. And it's that patient's imaging, and you hit it, and it'll literally correct the spine
and show what it would look like if you'd done it.
As if you did it.
Wow.
And then if that looks good to you, you can say, oh, that's good. They will then 3D print a rod that will fit with markings where every screw should be lined up for you to use in the operating room.
Holy cow. So essentially what you're saying is we're like seeing an evolution of AI with brain surgery and spine surgery, and the combination of those, like making these outcomes that we just never could have had before.
Yeah.
So on that, great question. How do you see AI changing potentially or influencing neurosurgery over the next 5-10 years?
Well, I see AI as a really, really useful tool. I think computers in general are great at picking out patterns. And I think AI helps us to extend ourselves. Now imagine if you could have patients communicating with AI, it could bring in, if you could feed your pre and post operative imaging, the patient's exam findings, their strength findings, like everything else that you do, like if you could upload your notes into an AI and have it figure out particular things that portend a good or bad prognostic indicators for a certain type of surgery. So where even a great data scientist at a very good academic institution couldn't pour through hundreds of thousands of patients.
For one person,
a computer could literally put together all the information from every spine surgeon in the U.S. in a matter of seconds.
Yeah.
And it could pour through them to figure out, are there certain things? Because ultimately, I think that's where the future is heading, is for it to be able to identify kind of patterns for us, to be like, this type of pathology responds really well to this. This type of pathology does not respond well to this. This type of surgical correction is better. This type of surgical correction has higher rates of failure. Yeah. Things in
the data analysis, like computers are just better
it can just do
at
it.
Analyzing it than we are. But there's things that we can do that I don't think will ever replace what we can do.
Oh, absolutely not.
And so people are like, is AI going to take jobs? And I think, AI is never going to take your job. I don't think so. But I do think that it can make you better at what you do.
Absolutely. I think there'll always be, I don't foresee a future in which you go into an ER and talk to an AI and it like spits out medication at you and a diagnosis, or like in Alien, where there's some pod that you get in and a diagnosis and treats you. I don't see that happening, at least in the next few lifetimes.
Yeah.
But I think AI can be really useful as an adjunct. It's sort of like Google. I think if you know what you're looking for,
it can be really useful.
I mean, like doctors use Google.
Yeah, absolutely.
Like it's like you can, because Google literally has every scientific paper that's ever been written
out there.
And so if I know what I'm looking for, I could very easily get it. And with the training I have, I'm able to interpret it properly.
Correct.
I think that's where AI is going to be helpful to kind of extend into that realm, because it can do what it would take thousands of humans to do. Yep. And it can bring you that information, but you still need someone at the end, on the other end, that can then make sense of that.
Yep.
And that can talk to people. Like, we don't have robots capable of empathy, as of yet.
Bedside manner.
Right. So there'll always be a role. I think there's always going to have to be a a human involved
Yeah.
in the actual patient care. But I think it's going to be really useful. It's another tool, and I think if we want to be the best doctors we can be for our patients, it's absolutely imperative that we use every tool that's available to us.
I'd agree. I actually think that AI has the capability of massively improving multiple processes in healthcare. I think one is a lot of the busy work of healthcare can be solved by AI very well. I think that a lot of the administrative billing, coding type of stuff that's not really healthcare,
Right.
but it's a necessary, like, I don't want to call it evil, but it's a necessary burden that we have to get through. I think AI facilitating a lot of those things and taking those away so we can focus more time with patients.
On actual
And then
patients,
secondly is what you just talked about, which is better data means better decisions means better outcome.
Right.
And if we can use AI to be able to process some of that massive amounts of data, like if I could take every single one of your medical notes you've ever done and be able to look at that and have an AI calculate that, and then I get to see you, how much more would I be able to talk to you about things that are important to you because of that process, right? So I think AI has huge potential. I don't ever think it's going to replace people in healthcare, just like you said. But if we can just get it to do some of those things to where it allows us to focus on patients, I think it's a win for everybody. So.
Yeah, absolutely. I feel like there's been a big, I think that there's been a big administrative kind of bloat in medicine.
Moved into medicine. It makes it expensive and slow. And
yeah, and there's just so many extra steps at every single step, and you need someone to oversee every one of those. So it creates inefficiencies. It creates, where people and things, information. Every time information changes hands, it gets lost. So I think having something to kind of streamline medicine a little bit, would be,
which would make it less expensive.
Right.
Huge cost savings.
The fewer people that you need to do a lot of that, regulatory work, I think is cost savings. And in an ideal world, those cost savings would be then given back to the patients.
Okay, so we've gone through so many different things today, and it's been awesome. A couple last questions. I brought up my feelings about chiropractic, and we were actually having a good conversation earlier about chiropractic. Just want to hear, what do you think of chiropractic?
Yeah, I think that chiropractic care absolutely has its role within treating patients, just like medication, just like interventional pain procedures, just like physical therapy. At the end of the day, my goal when a patient walks in with some sort of problem is to get them through without needing surgery. And I think I think every patient that I've ever seen who's seen a chiropractor has an excellent personal relationship with that chiropractor. I think having someone on your care team who you have such a good rapport with is never a bad thing. And I think there absolutely is a role in chiropractic care to help manage non-surgical pain. And then, if it gets to or even post-surgical pain. So yeah, I think I never discourage people from doing things for them that work. If it works for you, then that's ultimately, because patients are like, I do this, or it'll be, it'll be dry needling, physical therapy. Like, it worked for me. What do you think about it? I'm like, if it worked for you, you should keep doing it. Like if something is helping you, then you should absolutely do it. So
agreed. Yeah, like when we were building our team, as a multi-specialty group, it was interventional pain, it was med management, it was physical therapy, and chiropractic is one of those ones that I feel has gotten a lot more attention recently and a lot more research recently showing the effects of chiropractic and that it can be a great modality for like low back pain and other things like that, right? And I think that part of a care team, especially when you're trying to defeat the opioid epidemic, decrease reliance on medications, having those non-opioid modalities in your group has made a massive difference for our patients, and outcomes that we're seeing is patient satisfaction's high, patients are getting good relief, and then when we do need to bring in additional specialties and other modalities, it really can be great, because when it comes over to you, it's we've tried this and we've tried this and we've tried this.
Right.
This now needs surgery, and I think that's one of the great things about when we get to refer to you, is that we've tried a lot of stuff.
Right.
And so when it comes over, it's probably a really good candidate for surgery versus somebody that walks off the street. There may still be a whole list of things that can be tried before they get there.
Exactly.
Right? All right. So I have one last question for you. So if you were not a neurosurgeon, you couldn't be a doctor, what would you be?
Ooh. I was actually, when I was in high school, I actually was really interested in computer science. And for a while, I was alternating between chemistry and computer science as the two things that I was interested in.
Oh, wow.
So if you told me at that point that medicine was closed off to me for whatever reason, I probably would have pursued computer science. I really liked programming.
Probably be designing the AI we're using.
I would be here interviewing from one of the AI companies.
Right. Yeah, no, that's
yeah,
awesome.
no, that was my other big interest when I was in my formative years. So I probably would have gone into computer science.
Awesome. Okay. So if there's anything that, as we're closing this out, and is there anything you think is important for people to know about you? You're here, just so everybody knows, he's with Atlas Neurosurgery and Spine, incredible group here in Scottsdale, Arizona. But just last parts, is there anything that you feel would be important for anybody listening to know about you?
Really, I feel like the whole session with me just rambling about random topics is more or less me as a person. I try to know everything I can about everything that I can. As it relates to patients, I just my whole philosophy, like I said, is just if you come and see me, my goal is to develop a relationship with you, to be able to figure out what's going on with you, for you to tell me essentially, how we're going to proceed. So I would love to be able to quell some of the fears that people have about seeing specialists, which are not always unfounded. But in my case, I do like to treat each patient as if it was someone that I love and care about, and just to give the same options to them that I would want given to me or to my brother or my mom or dad. That's that, and I would hope that all medical professionals operate in such a way. But I think of every new patient I meet as a chance to build that relationship, to make that person comfortable with me, so that we can help get the best outcome for them.
Awesome. Well, thank you so much for coming on today. We really appreciate having you on. Again, Dr. Sharma is an amazing neurosurgeon, and hopefully you'll get a chance to meet him.
Thanks for having me.
No, but thank you.